Hello, my name is Jeff Taylor, and we're here with Dr. Ron Mitsuyasu from the University of California, Los Angeles. And we're here at the 20th anniversary of the Conference on Retroviruses and Opportunistic Infections being held in Atlanta this year. And it's an exciting time because there's been a lot of talk about the cure. They announced a couple of days ago an astonishing case of an infant apparently being cured of HIV. And there have been many sessions on various aspects of the cure, including the use of cancer drugs. And Dr. Mitsuyasu is one of the many hats he wears, is the chair of the AIDS Malignancy Consortium. So welcome, Dr. Mitsuyasu. Thanks for coming.
Well, thank you very much, Jeff.
And maybe you'd like to tell us a little bit about kind of the intersection of AIDS oncology and the cure work that's beginning to happen these days?
Yeah, I think all of us have been very thrilled by the fact that there are these so-called cures, whether they're functional or sterilizing, is another point. But the fact that some people can in fact clear their HIV, I think, is very good for all of us. Now, where we can learn some things from oncology are twofold. One, obviously, is that the so-called Berlin patient actually received a bone marrow transplant as part of his treatment and had to receive high doses of chemotherapy. That is not really feasible for the vast majority of people because of the toxicities. However, it may be a proof of principle, and so there are studies at the AIDS Malignancy Consortium in conjunction with a variety of bone marrow transplant groups are looking into, so that for patients who do require a transplant, we will get some additional information about what happens to their HIV. But I think more interesting is the fact that we're now borrowing from oncology with some of the newer agents. And these include not just monoclonal antibodies and certain cellular therapies, but even epigenetic treatments. These are things that work at the histone level. And one of these drugs that has received a fair amount of attention recently is vorinostat, which is histone deacetylase inhibitor. And that particular drug has been shown in single drug and in one case here at CROI in multi-drug studies to actually induce HIV replication. So it's this kick and kill, if you will, approach in which we're trying to induce the virus to come out of the cell and then destroy the infected cells. So we're evaluating that particular drug as a lymphoma treatment in conjunction with chemotherapy in patients with AIDS lymphoma. We also have a trial, or had a trial, that was looking at vorinostat in combination with other chemotherapy for solid tumors in people with HIV. And as part of those studies, we will look to see what it does to the viral reservoirs in these patients. And there are other drugs. For example, there are these so-called proteasome inhibitors, one of which is bortezomib. And bortezomib has a long and successful history as a treatment for multiple myeloma. And that particular drug has now been shown to have some activity in leukemia and lymphoma as well. And so where we think this might be useful is in people who have viral induced malignancies such as lymphomas and Kaposi sarcoma, where by utilizing this particular drug, we can induce the virus to go into its active phase, and as it replicates, it will destroy the cells. So we are actively looking at those potential drugs as well. So there are a lot of things that we can learn from oncology that could have bearing on HIV.
Well, it's fascinating. It seems like we're coming full circle because I think AIDS first became recognized because of chaos. That was one of the hallmarks of AIDS infection back when the epidemic started. So it's interesting to see it come full circle and that oncology is once again providing the answers and perhaps saving lives and even curing them.
Right. Yeah, and I think as we now are starting to recognize that cancer is a big part of the AIDS epidemic worldwide, I think as antiretroviral therapy become more prevalent around the world, we need to start thinking about cancers again, because this is clearly one thing that will ultimately cause people to die prematurely if we don't recognize it and deal with it.
Right. I mean, and cancer is one of the biggest killers of people with HIV. It's not AIDS itself, but the cancers.
Yeah, and it's become an emerging problem, not just the AIDS-defining cancers, but the so-called non-AIDS-defining cancers as well.
Perhaps you could speak to some of the research that the AIDS Malignancy Consortium is doing in places like Africa to address the specific cancers that are endemic there.
Yeah, well, the AIDS Malignancy Consortium had as one of its goals the development of a cancer treatment program in HIV patients in Africa. And so with our last recompetition of our grant, we did a survey of sites and selected 4 of them in Africa that are now part of our program. Our initial studies will be in 2 very prevalent cancers. One is cervical cancer, which is endemic in resource-limited countries, and the other is lymphoma. We're also continuing to pursue Kaposi sarcoma studies in Africa, where it's a big problem, in conjunction with the AIDS Clinical Trials Group. So we think that as we move forward, we not only need to get more data about the types of cancers that are showing up in these places, but also how to deal with them.
And do you think that there are different treatments than we use here in the U.S. that could be useful there? And is it just a matter of resources, or is it also different cancers and different treatments that are needed there?
I think it's both. We do know that in certain parts of the world there are prevalent cancers that are different than in the Western world, and that was shown nicely in a epidemiology paper here at CROI that showed that in India, unlike in the West, breast cancer and colon cancer are very prevalent in the HIV population, which is not the case in the West. And but there are also approaches that need to be looked at. For example, in Africa, high-dose chemotherapy would not be as useful if there isn't the intensive care units and the ability to give GCSF and other supportive care. And so we need to look at perhaps less toxic, maybe fully orally administered chemotherapy, and be able to compare that to standard chemo to see if in fact we get similar anti-cancer results while not causing as much toxicity.
And what else is the AIDS Malignancy Consortium doing this year that is different than what they've been doing in the past?
Well, I think there's a renewed focus on cervical cancer and anal cancer prevention, the so-called HPV-associated tumors.
Right.
We know that these tumors are still ones that occur with high prevalence in both the West and the East, and the North and the South. And so we need to kind of focus on how we go about identifying and preventing it, because most of these cancers don't occur overnight. They go through an evolutionary period, and if you can detect them early enough, we may be able to alter the course of development of cancer and prevent them altogether.
Yeah, that's ultimately the goal, is not to have cancer to treat.
Right.
Well, thank you so much for taking the time to join us here at CROI. I know it's a busy time for anyone with as many hats as you wear, so thank you for joining us.
Well, thank you very much, Jeff. I appreciate your time.